Are we on? Good morning. My name is Gretchen Wartman. I am Vice President for Policy and Program of the National Minority Quality Forum. Welcome to session 13 of our 17th Annual Leadership Summit on Health Disparities. I'm joined by three panelists who honor us with their presence. Dr. Georges Benjamin, Executive Director of the American Public Health Association, Dr. Doris Browne, the 118th President of the National Medical Association and President and CEO of Browne and Associates, and Mr. Adolph Falcόn, Executive Vice President of the National Alliance for Hispanic Health. For the past 3 years, the National Minority Quality Forum has functioned as a convener of thought leaders who represent the diverse community of partners to advise the All of Us leadership. This panel is a continuation of that role. Our topic this morning is expediting the pathway from community engagement to research, the opportunity for the All of Us research program. For those who may not be aware, I'd like to take a few minutes to provide an overview of the All of Us research program. The National Institutes of Health, through the All of Us research program, seeks to gather health and lifestyle data from 1 million or more US residents to inform a longitudinal cohort study that will be operational for at least 10 years. All of Us, which entered our consciousness as President Barack Obama's Precision Medicine Initiative, is an effort to enable more precise research that can lead to more effective therapies and thus reduce patient risk. Funding for the All of Us research program, up to $1.5 billion over a 10-year period, is authorized by the 21st Century Cures Act. Of particular interest to the National Minority Quality Forum, and I believe to the organizations represented on this panel, was the objective articulated by Dr. Francis Collins, the director of the National Institutes of Health, that at least 70% of the participants in the All of Us research program will represent populations that are HUBR, historically underrepresented in biomedical research. These HUBR populations include, but are not limited to, ethnic populations other than white non-Hispanic males, LGBTQ+ individuals, women of color, and individuals who reside in rural or non-metropolitan areas. The All of Us research program, therefore, represented a pathway to eliminating barriers to increasing the diversity of the population cohorts that have an opportunity to participate in clinical research. 2.5 years after full launch, approximately 300,000 individuals are fully enrolled. It's important to note that All of Us also represents an opportunity to increase the diversity of the researchers who have an opportunity to participate in clinical research. Therefore, administrative barriers to accessing the All of Us research workbench must be minimized if we are to maximize the potential of the All of Us research program to redress inequities in access to clinical research for both participants and researchers. The framework for our conversation this morning is the dawning consensus that regardless of the success of the National Institutes of Health and other research sponsors in enabling the creation of new science and evidence, our American system of research financing and delivery of both preventive and clinical services is not designed to be responsive to all populations. Indeed, I think it's accurate to state that our systems of research, financing, and delivery are designed to be, have been, and are non-responsive to certain populations. This is the foundational flaw that has engendered the cohort of Americans that are variously categorized as historically underserved, hard to find, or challenging to engage It is not a coincidence that these populations are, to a disturbing degree, the same populations that are now described as having a social determinants of health problem. A critical function of the National Minority Quality Forum is our capacity to collect, analyze, and publish data. Our analyses indicate a predictable pattern of preventable or amenable morbidity and mortality associated with chronic diseases, influenza, pregnancy outcomes, hepatitis, and certain cancers in these same populations. It also indicates compromised outcomes of care associated with the legal, regulatory, and payment policies that govern the behavior of both the public and private sectors. When coupled with the immediacy, with the horrors of the American novel coronavirus epidemic, this raises an alarm that can no longer be ignored. As a result, the National Minority Quality Forum is initiating discussions with thought leaders in the public and private sectors regarding the need for a dramatic reimagining of the healthcare system that inculcates reduction of patient risk as the operating principle. At this point, I would like to turn to the panel to give each of our discussants an opportunity to offer opening remarks. We'll start in alphabetical order. Dr. Benjamin, please go first.
Thank you very, very much. And everyone, I'm glad I can be here. You know, as you know, our nation is not as healthy as we need to be when compared to other industrialized nations, despite the enormous amount of dollars that we spend in our health system. And the American Public Health Association has, as part of its quest, to try to make the US the healthiest. But we can't do that unless we have a system with everyone in and no one out, and everyone having equity and the ability to achieve their optimum health. And so the All of Us program is designed through our eyes to make sure that we can have the inclusiveness of all communities of color, all underserved populations, all under-resourced populations in the whole research endeavor. And obviously, as you heard earlier from Gretchen, the issue is both the patients, non-patients actually, in many cases, and the researchers themselves. We believe that, you know, if we can get everyone in and understand the implications behind science on all populations, recognizing that 99% of us are, you know, genetically the same, but it's that 1% that is really driving precision medicine in such a way, because we know that that 1% makes an enormous difference in the relationship that people have with medications, the response that they have to those medications. And we just don't have the data to be able to make those kind of correlations appropriately. This program will help us do that. And what's playing out right now in this issue where we're looking at the COVID-19 outbreak, and the fact there's a lot of research going on, but we simply do not have enough people of color in those research protocols. We don't have yet enough people of color in the vaccine studies, for example. And so this kind of program can help us both encourage people to become more involved in research, to gather the data so that we can then do the cross correlations that's necessary for these better studies. So the American Public Health Association is strongly behind this program, and we want to encourage everyone to participate to the full extent. Thank you.
Thank you. Dr. Browne? You're on mute, Dr. Browne.
Thank you. Good morning, and thank you for inviting me to participate. I would like to start off by really giving you a few pointers about the W. Montague Cobb Research Institute that is part of the National Medical Association. The Cobb NMA Research Institute was formed about 14 years ago as a high-level think tank to respond to the solutions in answers to health inequities. And it has been through the vision and leadership of the Institute and benefiting from the long history that as a part of the National Medical Association history of advocacy that's going to focus us in helping to identify issues and developing solutions that should reduce racial and ethnic disparities. We have been a part of the All of Us research program since its inception as a provider engager component. And we see the performance of cutting edge work in medicine and helping to move along the Cobb Institute's engagement in the solutions as a trusted resource in the community. Today, we focus on the issues of the social determinants of health, and it is certainly helping to consume us as we address the worldwide pandemic of COVID-19. We have implemented strategies that help to provide or to identify the provider groups that will increase their education and awareness among the African American communities. We know, and from our focus groups and other awareness programs, that many patients do not participate in clinical research because their healthcare providers have not discussed it with them. And so we have hosted a number of programs and participate in events with our partner organizations to really stimulate enrollment of the All of Us programs in keeping with this mission to enroll 1 million individuals in this country. We recognize, of course, that diversity is key to answering those questions. And as healthcare providers, our healthcare provider organization, we really want to make sure that not only African Americans, but other underrepresented minority populations are part of this cohort of individuals. And because again, we know from our history that providers' primary interest across the board is really to maximize the limited time that they have with their patients and to ensure that they're going to receive high quality, exceptional care. And so therefore, Cobb wants to participate in the All of Us activities and initiative that will help to benefit the enrollment of our provider organizations and members to reduce the time that they're going to have away from patient care, but they're also going to engage in the research. And we know that there's some hard questions that have to be answered for our patient population because we understand and address the historical barriers that we've had. We do not try to get around them. Those are questions that's there, and they want to know, how is this study going to differ from other studies? In particular, even though there is a generation of individuals that don't even know about the Tuskegee experience, that is still on the mind of a number of individuals. So we have to answer those questions from them and not shy away from it. We have to answer the questions about what is it that our patients are going to be asked to do? And one most important for them is, how are we going to protect the information and their data? And those are very key questions of managing and providing that information. And the Cobb Institute has been on the forefront for answering those questions to the provider community and not shying away from those pain points, but looking at that as an opportunity for us to engage and increase the enrollment and provide feedback for the individuals. We know that at this time, the All of Us program has enrolled a significant number of underserved populations that have previously not been engaged in biomedical research. And we feel that because we are working with those provider organizations and collaborating with other partner groups to reach those communities that have not been reached before, answering those pain points and making sure that they are comfortable in giving their information, particularly as we now move forward with collecting genetic information. And we've heard that that 1% is really going to make the difference as we move towards answering the hard research questions that our patients will have. And so we look forward to participating in the continuously participating in the program as they move to the next level. Thank you.
Thank you, Dr. Browne. Mr. Falcone?
Good morning, everybody. It's great to see you. I miss seeing everybody in person, but I'm looking forward to better days ahead. But it is great to see everybody virtually. For those who don't know the Alliance, the National Alliance for Hispanic Health for 47 years has been the largest network of Hispanic serving health and human services professionals in this country. Today, our community-based organization members provide services to approximately 15 million persons a year. So it's a very broad, very deep service delivery network. And as part of that, we have a responsibility to make sure the best in science is reaching our communities. And just a couple of words about why we are so invested and so involved with all of us. We've been there since the beginning. And for us, we think it's important for science. Folks often think we're involved with this simply from a civil rights perspective, but for us, this is very much about good science. As you've heard, discovery is in the differences. And if you don't have a diverse group of folks participating in research, you're going to spend an awful lot of money and miss discovery. We can be spending our research dollars a whole lot better if we're invested in diversity in research. We're going to have a lot better outcome in terms of discovery. And besides science, for us, we understand that medicine is moving to precision medicine. Care tailored to the individual, something that we have always supported. But as part of that, traditional clinical trials are changing. And big data systems are going to become critical to clinical trials of the future. And if we're not a part of those data systems in the beginning, we're going to continue to not be a part of clinical trials in the future. So for us, this is critical work. Also on the horizon, we know that artificial intelligence is changing how we deliver care. The problem is we're basing artificial intelligence on data that does not include us. So for us, all of us is also an opportunity to start driving those kind of artificial intelligence decision systems in health so that they include a full range of information so that those artificial intelligence systems don't become a harbinger of new barriers to underserved communities. I bristle a little bit at the term of hard to reach because it's a false premise, I think. All sorts of research shows us that if traditionally underrepresented communities are asked by a trusted person in the healthcare system to be involved in clinical research, we are more likely to enroll the non-Hispanic whites in that research. And all of us is an example of that. You heard Dr. Browne mention she's been there at the beginning. We've been there at the beginning. And that's a real difference. Being invited at the beginning to help design what is going to be delivered has made a real difference in the All of Us program, being able to deliver research and registration and participation numbers that are very close to our representation as different communities in the general population. And that's a sea change. It shows that community-based participatory research works and can be done. But it didn't happen, and I want to end on this. It didn't happen by happenstance. It was very purposeful. A lot of us on this call today were involved in the original Cures legislation, and we advocated for diversity in the All of Us program to be written into the founding legislation. So I just want to lift up that role of advocacy. You know, a very smart member of my network once told me, you know, Adolph, we've known since 1985 in the Secretary's report that we weren't included in research, but that shouldn't be surprising because that's a reflection of our values as a nation. Throughout history, we've always counted what we valued. So we need to change that value proposition. We are a part of this country. We pay taxes at the same rate as everybody else, and we are financing this research system. As the purchasers of our national research enterprise, we need to be included. And advocacy is a central role that we all must play as scientists to move forward research. And I'll end it there.
Thank you. As the panelists know, I've prepared a few discussion questions to prompt the conversation. I would also like to remind the audience, if you have any questions, to please enter them in the Q&A box, not in the chat box. I was reviewing the questions to look for the easiest one to start with, but the problem at this point is that there are no easy questions and there are even definitely no easy answers. So I'm going to sort of remind Adolph that at, I think it was the first Thought Leaders meeting, he reminded some of us that we've been having this same conversation since we were using great big discs that a friend of his identified all of the different media that we've used to capture information. And I go back to a time when we didn't even have computers on desks, that the notion that staff would have a computer on the desk was considered folly of some kind. So the challenge we have, I think, is from the perspective of sort of tabula rasa, because we've made some progress, but as everyone has pointed out, we're continuing to contend with the same challenges of bringing what is now what is a growing and actually majority of our country into the research enterprise, into the healthcare enterprise. I think it was clearly not envisioned at the time this system was designed, but we are here, we pay taxes, we're charged the same amount, we suffer and die at greater rates than others. So to setting aside concerns about how we'll pay for it for the moment, I'd like to ask each of you to speak to your vision of, or your priority for a redesigned, a reimagined health services research delivery and financing system that does indeed assign value and engagement to us at the very beginning of the conversation, not just at the point when we're an opportunity for a billing. And I'll start with Dr. Browne.
Yes, thank you so much for that question. And yes, our healthcare system really needs to be reimagined, as sort of a new term. I believe that diversity drives the science. And so when we look at our healthcare, we have to have a diverse healthcare system, a diverse healthcare workforce. And as I've heard also, we have had over the years, we've spoke about this, but yet when we look at the number of minorities that are entering medical and other health professional schools, the numbers are really going down instead of going up. And that is an area that we really need to work on to make sure that our workforce, because it is a key part of the quality of healthcare that we are going to get. We are advancing and working on a number of technological things, and that's really wonderful. AI and smart technologies are really wonderful. But if you have not researched that in a diverse community, then you don't know whether it is really going to be effective in the communities that you're working on. And I would say from the COB NMA standpoint, we see that we can collaborate. And I think it really is going to help us to move away from working in silos where we have in the previous years, to moving into a collaborative approach to get the synergy of working together and advancing that. And I think that's really where we're beginning to focus our interests at this point. And using COVID-19 as a primary vehicle to answer those kinds of questions, it's really important because it involves your education, your transportation, your first liners, all of the systems working together as well if we are going to get out of this pandemic with any substantial numbers. Thank you.
Mr. Falcon?
Well, you know, I want to echo one thing Dr. Browne said. We often get enamored of high-tech solutions. Those high-tech solutions right now don't reflect us. But I think it's important to also not forget the importance of high touch. The personal interaction, the art of medicine, you know, we can't lose, and the people matter. You know, we've seen it in the research enterprise. All of us, to our perspective, has worked because trusted community organizations, trusted community health providers have been engaged, and they are talking one-to-one. It's that high touch is critical to advancing science. But in terms of changing the research enterprise, one of the things that we have been advocating for is a diversity score in research, that every research proposal funded by NIH should have a diversity score, because without a high diversity score, that research is doomed to not be effective. And you know, I think we need to flex our power not only as advocates, but flex our power as consumers. And within NIH funded research, as taxpayers, we are funding that research. And I think we have a right to understand whether or not proposed and funded research meets standards of diversity. And if it doesn't meet those standards, it should not be funded. And those diversity scores should be publicly available on all publicly funded research. And as part of the COVID-19 trials, we've been talking to pharmaceutical companies as well about the importance of inclusion from a business perspective. If this vaccine is not adequately tested to know whether or not it works in African American and Hispanic communities, unfortunately, we are the very populations being most affected. And that vaccine research is those funds invested are not going to deliver on the business case. And that's true across all pharmaceutical funded research. You cannot, we are becoming a majority minority nation. The whole premise that you could have a pharmaceutical research enterprise that doesn't adequately include who are today underrepresented communities simply does not make business sense any longer. So to our mind, reinventing the enterprise means being involved as advocates, but it also means flexing our power as consumers to change the research enterprise, to change discovery, and to change delivery systems.
Thank you. Dr. Benjamin?
Thank you. You know, one of the practical things is that when you go into a research program, a fair amount of what happens in the research enterprise is compensated for. But a major barrier to getting in there is basically having basic health insurance coverage. The lack of basic health insurance coverage often means that you don't have linkage with a medical provider. You don't have a physician-patient relationship. And we know one of the strongest ways for people to get into research is through their primary care provider. Those providers know the protocols, they know you, they understand what your needs are, and they serve as a conduit to, in many cases, getting into research programs. So having a system that does not have everyone in and nobody out, I got to tell you, is a major barrier to making sure we have equity in research. It does a bunch of things. It pays for those non-research things that the research protocol doesn't pay for. They also pay for a fair amount of the pre-care and aftercare that occurs outside that research protocol. So I would argue that universal access to healthcare, so that everyone is covered, is going to be extraordinarily important as a baseline to improving the research. It also benefits the researchers. So obviously having researchers that are of color and in underrepresented minority groups who can do research, well, research doesn't pay the bills. And so they've got to have a functional practice to do that. And they also have to be, even if they're in an academic research center, being able to adequately have the resources to support those programs. That's particularly true in our historical Black medical schools, making sure that they have adequate resources to pay those bills. So, and the overhead and the indirect, because the research endeavor is very, very expensive. And again, the research protocols don't pay all the bills. So this is kind of a very practical, I think, approach to doing that. But I think it's something that's extremely important if we're going to move. And that's something that we absolutely need to make sure that we're moving towards in the next 4 years.
Thank you.
I add one point to that.
Certainly.
Just wanting to add one point. I think Dr. Benjamin has brought up a key part that is missing. Our HBCU institutions, particularly those that are engaged in research, don't have the infrastructure dollars that are there. And many of the research programs do not allow that to take place. And so perhaps we need to advocate for getting more funding put into infrastructure that is designed to go to our institutions so that we can then get on a level playing field. And I think the other key part of this, we have to advocate for the community. And as Mr. Falcone has indicated, we need to be at every level of the research program. We want to be those that design the program. We want to be those at the academic institution that's going to implement and deliver that. And then we want to be there to disseminate that information that is gained back to our communities. So at every level, as the trusted agents that's going to be engaged.
Thank you. And my follow-up question is for any of you, so you can unmute yourselves at this point. I want to follow up on a couple of things. One is, I think, a legitimate concern about, from what we're hearing, the loss of the value of the human touch and the human eye, using all of our senses to engage with other human beings. But I also want to speak to what I think is being recognized as the potential value of more aggressive use of technology, of artificial intelligence, if you will, or whatever they call it, to expand the capacity of our system to deal with the growing numbers of people who need to be served, the increasing variety, because it's not just the sort of what we know now to be the genotypic and phenotypic variety. But as the science progresses into what is truly the potential for precision medicine, we all are to some degree becoming a rare disease, a rare case, if it truly becomes precise. And I think a case can be made that artificial AI can help us move in that direction more rapidly. So I'm asking the three of you to, in the interest of reimagining, really, speak to ways we can use AI, not only to have a more responsive system, but maybe to eliminate some of the human bias that comes with that human contact. And I think, as we all know, those human biases are not just based upon visible differences, but also the perceptions of caste and class that we all bring to human interaction. So how can we use that? And I'll add one more thing just to complicate the conversation. Several years ago, 10 maybe, Dr. Michio Kaku spoke at our awards dinner, the Summit Awards dinner. And he suggested that instead of trying to resolve some of the issues by creating more clinicians, that we find a way to merge that knowledge that we have with AI, so that when that human clinician is brought into the conversation, they're operating always at the top of their license, at the top of their game, and that AI can somehow take on some of the role that simply more personnel would be required to perform. So I'll start with Dr. Falcone, Mr. Falcone this time, and then go to Dr. Benjamin and Dr. Browne.
Well, I think, as we've all mentioned here, AI in medicine is proceeding at a pace that outpaces our knowledge. We are implementing systems. We are currently implementing systems that, frankly, are based on bad data. And the problem with that is the outcomes can be fatal. One example we've often talked about is heart failure in African American males and post-treatment. There are differences in the best protocol and the best treatment, and a lot of the protocols are not programmed right now to reflect that. And there's a very direct impact on outcomes, including fatality after heart failure events. And it's true across a whole series of diseases and illnesses. There are differences in the Hispanic community with regard to asthma treatment, with a number of treatments for mental illness. There are different dosing requirements that the data shows us that we know, but those aren't making it into artificial intelligence systems that do assisted delivery or protocols to assist providers in treatment. So, to my mind, artificial intelligence is one of those areas that simply has not had enough researchers of diverse backgrounds, and we have really not addressed the issue. And we're behind the ball on that right now, because artificial intelligence is just rolling in terms of how we deliver medicine. So that's one thing. The other thing is, I think one thing we've learned about being at home is that there are other ways to provide high touch. What we're doing right now is one of those ways. We are looking at how do we do a better job of being virtual providers. And there are a couple of things I would point out here. One is that we have to expand our definition of providers. One of those health professions that's been lagging in recognition, I think, are promotoras, lay health educators, and the role that they can play in extending the reach of physicians and other prescribing providers. They can do a lot of the work that deals with the social determinants of health, that really provide better information to the provider on that patient's particular home environment, nutrition habits, family stresses that all have an impact on health, but that providers often don't have that kind of information that would benefit the type of care they're able to provide. And I bring that up because for me, a really interesting situation has happened in the state of Texas, in that very recently they have certified a promotora-based home visit program to address COVID-19, not only in terms of early identification of what might be symptoms for COVID-19, but also for dealing with patients in terms of outcomes from COVID-19 that often aren't addressed, like mental health issues and other issues that we are now finding after, quote, recovery from COVID-19 are having a real impact on communities. So that's the second thing I would say. Besides really getting involved in AI and improving the information that's going into AI, we have to start looking at how we can use virtual systems, and not only where they've been used traditionally with prescribing providers, but also all the other health professions, including lay health educators and promotoras.
Thank you. Dr. Benjamin?
Yeah, so I remember being in my internship, my first year residency, seeing the first CAT scans, just to say how old I am. And those were these old grainy things, and we look at the brain and we couldn't figure out how anybody could read those darn things. And now the technology is in color and in 3D, and you can slice it and play with it and manipulate the tool in a variety of ways. And they're wonderful technologies. Fast forward to coming into an emergency department and being seen in a patient that was turned over to me, who came in with severe back pain and was about to be discharged as a person with a renal colic. And I went in because of good emergency physicians, even though the doc before me said, you can discharge this guy. That's, we're just waiting for this one test to come back. A good ER doc goes back and takes your own history, talks to the patient, and looks at their exam and their testing. And I did that. And quite frankly, didn't find anything on physical exam. The patient had been given a fair amount of pain medication. He was a physician, by the way, and he was up and about on a phone because he was in town to give a presentation at a medical conference, trying to arrange for someone to do his presentation because he was gonna go back to the hotel and rest. But the story wasn't right. The story just didn't make sense. The long of that is that I went back and looked at his diagnostic tests, and they were okay, but the story wasn't right. And the bottom line is he had a dissecting thoracic aneurysm. Test showed it a little later that day. I was able to convince the internist on call that, this guy's story wasn't quite right. And when the internist came in, he said, there's something odd about this story. He just, when you've seen a lot of renal colic in the ER, you've seen a lot of renal colic in the ER, and there's a couple things that just weren't right about this guy. And I just say that to say that one thing I learned in medical school and all my practice is that technology is wonderful, but it should wrap around your clinical instincts. And so we need to use as much of the technology as we can. But at the end of the day, we do need to deal with conscious and unconscious biases. But I can tell you that one of my biases that day was that doctors always come in with bad things when they come into the hospital because we don't like to go to the doctor. And that anybody who turns a patient over to you and says, yeah, he's okay, just check this test, and then they can go home. That has gotten more emergency physicians in trouble than anything else, which requires, you going back over the patient and re-examining them. And then fast forward to my time in public health. And again, recognizing that we have a lot of people that want to sell us all kinds of tools. After the anthrax letters, every consultant in the world was there trying to chase the money, the new money coming down the pike. With COVID, we got all these tools to track, to do contact tracing supposedly. And yet, we're not doing it very well in our country. So I'm for the intersection because I'm a technology geek. I'm for the intersection of technology, but it should make you more efficient and not replace you. We're going to need physicians. We're going to need the people operating at the full highest level of the clinical training and practice. And as Adolph pointed out, we need to make sure that we expand the number of people that are practicing in this area. And there's many things technology can do to lighten our load, to help us move along quickly. But we need to be very, very cautious and plan that future and not let the technology, in my mind, drive it.
Thank you. Dr. Browne, did you have
Yes.
a comment?
Agreeing with both of the previous comments. In particular, the technology is important because it's honing down to give us that fine edge. But I think you have to remember that all of these technological tools depend upon data. Data in, data out. So there was an old saying, if you have garbage in, you're gonna have garbage out. So again, we want to be very careful that we are there honing the data and that it is going to be specific for our needs when we put it in. And we should be, again, having that keen thought. I mean, human touch should never go out because it's almost like that sixth sense that you sense that something does not quite fit. That's going to help you to let's re-evaluate, let's go over it again, rather than saying the machine said this and this is what it should be. So I think that's really the key. And for the other part, as an oncologist, we've had patient navigators to assist us in getting that information out and bridging things with our community. And so it's really going to be key whether we have the promoteurs, the community health workers, the navigators, all working together. I mean, this is a family and we all have a role to play. And all we need to do is work together in a synergistic way to deliver the best possible care using the technological tools, but with our common sense. We can get this done and get out of the health disparities that we are often faced with.
Thank you. I'm going to, I think, what I'm hearing is, and I think we all agree, we need to find ways, make sure that we're able to engage with the technology, the artificial intelligence that we have in a way that does not further compromise the care that's provided, and keeps the human perspective in control of the conversation. And I don't mean that in a negative control, but because the presumption is that the human being, I think, a safe will always ultimately care more about the outcome for the patient than the machine will. But I do also want to, and this will be the last question before we, I think, go to the Q&A box. Following up Dr. Benjamin's reference to CAT scans, one of my early jobs was doing certificate of need reviews for CAT scans in Southeastern Michigan, pursuant to Public Law 93-641, which is the only thing I remember at this point. And at that time, the issue, as always, was escalating costs of care. And scanners were only viewed as treatment, not diagnosis, as a tool for treatment, not a tool for diagnosing the patient. And when I was in the Health Systems Agency in Southeastern Michigan, and as we were the young people then, what Gary referred to this morning as young Turks, we were young. We would offer suggestions that perhaps they could be used more broadly. If you can use it for the treatment, and it was particularly in the oncology space, why are we not using them as sort of as a standard diagnostic tool? And we were told we were foolish and young and didn't understand how the system really worked. And I'm saying that because I'm concerned that just as the processes were in place to constrain the introduction of new technology into the system in a way that has ultimately served to significantly enhance the quality of the care and patient outcomes. Just looking at CT scanners as an option. We're also looking at other processes that are currently in place, these clinical effectiveness reviews, qualities, other kinds of assessments, that in our concern is that they too, while a case can be made that there is a legitimate concern about expenditures on ineffective responses, but making sure that it's truly an ineffective response rather than assigning a value to the potential recipient of that service, but also that those kinds of reviews are not serving, just as the certificate of need reviews did, constraining introduction of new knowledge, of new information, of new technology into the system, because what that they also do is discourage new sponsors from exploring new avenues if the concern, this is our concern, if the concern is that even post FDA approval, that the market will not be receptive to this advance. And so I'm going to open the door to either of the three of you, any of the three of you who would like to respond first, but I would like to hear from all three.
Well, let me start. I mean, as you know, the way those things were designed was around money, right? It was all about cost. It was to try to prevent very costly investments to be made in a piece of technology in one place that was duplicate something right down the street. So geography and cost were the primary drivers. Eventually, as we begin to understand more about the value in utilization, meaning recognizing that the more you did something, the better you got at it, that factor got thrown into the CON process. But we still haven't really, I think, looked at it holistically enough in terms of its value and maybe its potential value. The health system is one of the few sectors where we continue to add old tech, new technology on the old technology. New technology doesn't necessarily replace the old technology. It becomes additive. And we've got to get better at bringing in new technologies that are not additive to the system. And the other thing that happens is the cost per case doesn't necessarily go down. If you buy a radio the next version of the radio that's even more fancier, that's fancier than that, and have more bells and whistles, often is cheaper. And that doesn't happen in the healthcare space as it ought to. So the market is very perverse in the healthcare space for those kinds of things. So we don't have the full evaluation of its utility, and we quite often don't look at its future utility. All these smart devices we're wearing, if one goes out to what their future utility is, you can literally stop having to do vital signs in the clinician's office, because when you walk in, the system could theoretically just pick up your vital signs, right there. At least pulse, respiratory rate, pulse ox, in fact. Might still have to do a blood pressure. But the point is that we're not building that technology yet in a holistic way for the future. At some point, we're going to have sensors that can measure your probably your complete blood count and the whole range of your electrolyte functions, and maybe the old chemistry tests. So we ought to recognize the fact that we need to build those technologies in a way that not only do they help us clinically, but the fact that they can really enhance our ability to understand patients. And then let me add one more thing. That data, because Dr. Browne is absolutely correct, bad data in gives you bad data out. But if you can get that good data in, and that data can be, with your permission, sent to, a database somewhere that can gather that data, and that we will ultimately need basically a patient identifier so we can get rid of duplicates, and then have the system dedupe that so that researchers can then look at population-based data without looking at individuals, so that you can maintain confidentiality. Boy, that's a vision for the future. This data would just go in, and in essence, what you're doing is you're crowdsourcing. You're crowdsourcing your data, you're putting it in, you're deduping it so that it's not aligned to any individual except for the clinician that needs it to manage that individual case. We could dramatically accelerate this program and our ability to understand research and what's happening to communities through various population lenses. But what's happening? We're building individual apps. We're doing this without a grand vision. And we really need to have the grand vision, I think, if we're going to be successful at this.
Okay, thank you.
I would just add one point, is that I think that grand vision is really what is seen in the All of Us cohort, and that given time, we will be able to look at this broad base of data. I think the caveat that we really have to keep in mind and should be utmost in our thoughts is that all of this data and information that we're going to have should not be used in any way to be a discriminatory factor. I mean, we want to get out of who's on top and who has privilege and not. And I think with the All of Us, the data honing and the de-identification, we will be able to get those questions without having it in a discriminatory way. And that's really going to be key if we allow certain identifiers to be there to then tell us what we're looking at, and you can discriminate against one group versus the other. And that's something that we always have to be aware of.
Okay, thank you. So I think here's what I'm hearing, and I think there's a consensus here, which is that we have to improve our ability, whether it's promontorists or clinicians, primary care clinicians, whether it's academic researchers or whether it's artificial intelligence. We need to improve, we need to create a system that defragments, to use an old term, the manner in which we're engaging with the patient population and links them in such a way that they work to the advantage of the population and not just a particular sector. And I'm going to submit that right now, that needs the human beings who are committed to assuring that those of us who are defined as having negative social determinants of health don't simply continue to have those negative determinants in a way that is reinforced by the system programming that will perpetuate those biases. So I think I think I'm at the end of our time, but I'm going to ask each of you if you have a closing statement you'd like to make, 30 seconds each. Please feel free to do so. Although this has been a spectacular session. Thank you so much.
Hi,
Dr.
this is Doris Benjamin. Vote. Just vote.
Absolutely critical. We must vote. And remember that healthcare decisions are shared decisions with our community, our patients, the system in which they're operating to give the best quality healthcare.
Thank you.
And I would just echo the vote message, and on the research side, to everybody who's attending today, make sure you're a part of the solution. Go to joinallofus.org/juntos, JUNTOS, joinallofus.org/juntos. It's the first step to be a part of the research solution.
Thank you. My thanks to all of you for joining this panel. This has been a unique opportunity, I think, for us. And I think the next link to the next session will appear in the chat box. For those who are interested in pursuing more information regarding the political determinants of the social determinants of health, I would refer you to the book that Daniel Dawes just authored on the political determinants. And Mr. Dawes is the director of the Satcher Leadership Center, I think it is, at the Executive Leadership Center at Morehouse School of Medicine. Thank you all for joining us this morning.
Thank you.
Thank you.
Yes.